This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you new here, welcome. For those of you who are regulars, welcome back. We are a continuing medical education podcast coming to you from UPMC Children's Hospital of Pittsburgh and the Paul C. Gaffney Division of Pediatric Hospital Medicine. I've been saying it all year. I'm going to keep saying it all year. This is our 10-year anniversary. October of 2016 is when we started this little venture together, and here we still are. So thank you for letting me come into your ears for the past decade. So this particular series is one of our two series we're doing this year. This one is the vaccine preventable illnesses. It's very near and dear to my heart. All my kids are fully vaccinated. I strongly support vaccines as a pediatrician. And I'm sad that we have to talk about it, but we do. With the changes in the world, the CDC, everything, there's a lot more vaccine hesitancy than there even was. And I found that hard to believe. So we are doing this for those healthcare providers who are on the front lines talking to patients who are going to have a lot more questions about why should my child get this vaccine? When was the last time anybody saw this condition? What does it even do? So we'd like to have you be fully prepared to answer all these questions. So we're reviewing everything. And for these episodes, I've been fortunate, very fortunate, to partner with my colleagues at the Division of Pediatric Infectious Diseases right here at UPMC Children's Hospital of Pittsburgh. They have been kind enough to lend their time and expertise to help us out. And today we're covering tetanus and Hep B in that order. And we have two wonderful experts here to help us out. So we'll start in no particular order. Dr. Glenn Rapsinski is our first guest. He's an assistant professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and the Division of Infectious Diseases. He's a pediatric infectious disease physician scientist, specializes in bacterial respiratory tract infections, particularly ventilator-associated infections. He was heavily involved in the community vaccine collaborative during the COVID-19 pandemic, which provided evidence-based information to the community about COVID-19 and SARS-CoV-2 vaccine. He was the course director for the Calling the Shots Intro to Vaccines elective at the University of Pittsburgh School of Medicine, lectured on the topic of vaccine preventable illnesses and how to communicate with the vaccine-hesitant people in the School of Medicine, UPMC, and in our community. And our second host, we're going to welcome them both together. Our second expert is Dr. Marian Michaels. Dr. Michaels is a professor of pediatrics at the University of Pittsburgh School of Medicine. Her pediatric infectious disease training was at the Great Ormond Street Hospital for Sick Children in London and at the Children's Hospital of Pittsburgh. She is faculty here at UPMC Children's Hospital of Pittsburgh since 1992 in the Division of Infectious Diseases. She's worked extensively with infections in children, both in the clinical realm and in research, with much of her work dedicated to epidemiology of infections, prevention of infections through vaccinations, and infections in an immunocompromised host. She's a PI for a CDC contract performing surveillance of children with acute respiratory infections or acute gastroenteritis to better understand outbreaks and determine how well our vaccines work today. And Dr. Michaels is going to help us out with a few things today, but we are fortunate to have both of our experts. So Glenn and Marian, thank you so much for joining us.
Our pleasure.
Thank you for having us, Tony. I'm glad to be here to help spread good information, but also I agree with you that it's sad that we have to have this conversation at all.
Yes. Well, we're here. Before we start, we got to do our disclosure as this is a CME podcast. I will go first. And Glenn, I'll kick it out to you. And last, but of course not least, is Marian. So I have nothing to disclose.
I have nothing to disclose.
All right. I always have something to disclose. So I do some research work with Merck, but nothing related to today's topic. And then I do have NIH and CDC funding for research, but again, not related to today's topic.
Well, thank you for disclosing that, Marian. We are going to start today with tetanus, and we have a format for what we're going to do. So why don't we start with the basics, going back to Microbiology 101, back in med school first year. Tell us about tetanus, please. What is it? Bacteria, virus, fungus? What are we dealing with?
Yeah, so tetanus is caused by bacterium, Clostridium tetani. It is a gram-positive bacterium. So if you remember, they're the purple ones on the slide whenever you're looking at a gram stain. They're spore-forming bacteria, and they're rod-shaped, and they grow anaerobically, meaning they don't like oxygen to be in their environment when they're growing. And so there's many different species of Clostridium that can cause human disease. We have botulism and C. difficile diarrhea. Well, Clostridium tetani is a bacteria that lives specifically in the soil, and it gets in the skin through contaminated wounds. When it's in the skin, it then makes a toxin, and that's really what causes the disease in patients. The bacteria isn't particularly invasive. It just kind of sits in that one spot and makes toxin that can get out into other parts of the body. And that toxin is called tetanospasmin toxin. And we'll talk about the effects that it has on patients whenever we talk about the presenting illness, or what a patient may look like when they present with this illness.
Well, all right. So then, epidemiologically is where I like to go next. So, how much of tetanus are we seeing? And then, ideally, how much did we see before we had a vaccine?
Yeah, so tetanus is one of the vaccine preventable illnesses that we've really gotten down to a very, very low rate in the United States. In particular, at this point, we're actually seeing in the U.S. less than 40 cases per year. That's as recent data as 2023 from the CDC. Back in 1900, so right around that time is when the tetanus immunoglobulin, which was the treatment for tetanus that we could do, that was not a preventative measure that you would give like a vaccine really far ahead of time. It would be like at the time of a contaminated wound. Around 1900, it was more like 700 to 800 cases per year. But the thing about tetanus is its fatality rate is so high that those 700 to 800 cases a lot of those were deaths associated with that. And really, the reduction in tetanus, I think, comes from a lot of different things, including the development of TIG, the vaccinations, as well as just improved sanitation and hygiene in the United States. On the other hand, though, as recently as 1980s, it was estimated that 2 million cases of tetanus occurred worldwide, and 1 million neonatal deaths from tetanus were happening as recently as the 1980s, with 100,000 non-neonatal cases leading to fatality as well.
So, worldwide, we're seeing more cases, but the fatality rate's very high with this.
Well, since the vaccines have gotten out and been spread kind of through philanthropic efforts, and we're improving hygiene for things like birth and everything that in less developed countries, we have seen a nice decline in tetanus over the last 40 years. But like I said, as recently as the 80s, we were still having a lot of tetanus worldwide.
Okay. So now, with potentially less people getting vaccinated, we may see more of this. So what would a patient look like who comes in with tetanus, assuming they're unvaccinated?
Yeah, so as I mentioned, tetanus is like the disease manifestations primarily come from this toxin that the bacteria make called tetanospasmin. This toxin ultimately blocks inhibitory neurotransmitter signaling in the nervous system. And so those inhibitory neurotransmitters help keep everything nice and calm and settled in your nervous system. And so when you get rid of that, you're much more prone to have activation of your nervous system. And because of that, you have this rigidity that occurs in your muscles as the pathogenesis of tetanus, because those inhibitory neurotransmitters are gone. And so that rigidity usually first manifests as trismus or lockjaw that we see in patients. And so that can be often the first thing we see. And in over 50% of cases, it is the first thing that you see. If the patient doesn't have trismus, they may have other things like irritability, restlessness, stiff neck, or difficulty swallowing. They can also have rigidity of the chest and abdomen. Eventually, this will go on to progress to worsening and worsening rigidity, to the point that there are lots of pictures out there you may remember from a medical textbook showing this arched back that the patient has, because they're so rigid at that point that they just can't, like, everything is stuck and frozen in that contracted state, that their back is arched. The sardonic smile that we see as part of tetanus as well comes from all of that muscular contraction that's completely uncontrolled at that point.
So I guess my question is: would infants, since you said infants can have a higher incident in worldwide as of 1980, infants had a higher death rate. They were the larger group of the ones dying. Do they present the same?
Yeah, so I'm going to actually defer that to Dr. Michaels, because she did a lot of work in Africa where there was a lot more neonatal tetanus at the time that she was there, as opposed to in my career. I've only stayed in the United States, and we really don't have any neonatal tetanus here.
Yeah, it's the benefit of being older, or maybe the benefit of being younger and not seeing it as the benefit. But in the late 1980s, early 1990s, I had the luxury and really the wonderful experience of spending some time in doing work in Africa and in Ghana and Kenya. And in Ghana in particular, which was earlier in the late 1980s, there was an entire ward that was filled specifically with infants who were born with neonatal tetanus. And in large part, this was because the mothers had never been immunized. And so they had no passive antibody to pass on. And then they didn't have good cord care. And they didn't even have sterile blades for cutting the cords at that time. And so these babies would present originally with, some lethargy, but then they would go into the most intense spasms and pain, and we put them on a ward very far away from anything else because you wanted it to be quiet. When you were going to that ward, you started to tiptoe, to walk softly, because anything that would agitate these children, noises, anything, would just send them into the most horrendous spasms and rigors that you could imagine. You couldn't, these poor babies, that it was just horrendous. And with a massive vaccine program to immunize every pregnant woman so that they'd have passive antibody, to give all the midwives sterile blades and good cord care training. When I talk to my colleagues who were in Ghana, even 5-10 years later, the wards were closed because they didn't have it. And I will tell you one further thing, because that shouldn't happen in the United States. It shouldn't happen anywhere. This is a painful disease that we can prevent. But there was a case in Children's Hospital of a mother who didn't believe in immunization, and her baby came in with this disease. And in America, we intubated that baby so that we could knock them out, so that we could completely put them under such sedation with so much morphine that they wouldn't be able to breathe for themselves until they could get through this disease. Just horrendous. And really, I'll let my dear colleague and friend Glenn take over in terms of treatment and things, but really a disease that is so painful you'd never want to wish anyone going through it.
Marian, before we kick it back to Glenn, I have to ask, how do you examine kids on an award like that when anything that startles them will send them into pain? It's the most genteel exam ever, has to be. Am I right?
Yes, you are very careful. And there we didn't, unfortunately, in those days, now it's different, but in those days we didn't have always sufficient oxygen or ventilatory assistance. So really, you would treat with penicillins, you would put an NG tube down them so that they could have nourishment, and you would try to keep them as calm as possible.
That's absolutely fascinating. Marian, that's a great story. That's just absolutely fascinating. We may end up circling back to it just because I want to hear more. But back to what we're doing. So we've talked about mortality rate. The mortality rate is, Glenn, can you give us a number for the mortality rate? Do we have one?
Yeah, so the number, I mean, it varies a little bit, I think, with advances in medical care, as Marian kind of alluded to. I think we've gotten that mortality rate down, but it can be as high as 80 to 100% mortality rate, depending on where you're at. I think nowadays the mortality rate has gone down over the time since the vaccine was introduced to childhood, which in 1947, it was 91% and then fell down to 44% by 1976, and was, as of 2017, was down to 6%, with the majority of the fatalities happening from tetanus in the elderly population, in a more elderly population.
Is there any morbidity that can happen from getting tetanus from going through it?
Yeah, so we talked about all these muscular contractions and these spasms that these patients are going to have. And as part of that, that comes with a lot of difficulties, right? If you can imagine, if all of your muscles are contracted, you're not going to be able to breathe sufficiently, and you can go into respiratory compromise. That respiratory compromise can ultimately cause hypoxic brain injury because they aren't able to breathe sufficiently. It can cause rhabdomyolysis because your muscles are constantly contracted and they're going to break down because of that. In addition, the toxin itself can cause a cardiomyopathy. It can also cause a couple of nerve palsies, including the phrenic nerve and the laryngeal nerve. And then you can have renal failure because of the rhabdo, and then potentially, and as you can imagine, a child going through this and experiencing this inability to control their own body could end up having a lot of psychological effects after the fact as well, like with some, PTSD and stuff like that coming as a result of having this illness. In addition, there can be a lot of autonomic dysfunction associated with this. So they can have blood pressure lability, so they can be really hypertensive or really, and go in between hypertension and hypotension, as well as tachycardia and arrhythmias associated with this as well. And because of this autonomic dysfunction, a lot of profuse sweating can occur as well.
Yeah, I think Marian said it best. It's a horrible disease. We don't want anybody to get it.
Yep. I've seen I think we've had 3 or 4 here at Children's since I started here about 10 years ago. And that, and the 2 that I saw, just watch when we lifted the neuromuscular blockade, you could just watch the muscles start to contract and they would rise off the bed just because their back was arching so much. And I can only imagine how much pain is associated with that.
Oh, so the next thing we have to cover, which we've talked about a bit, so I'll let you pick how you want to cover it, Glenn, is we wanted to cover what happened before and after the vaccines were passed in terms of incidents, et cetera. So we've talked a little bit about, for this particular condition, hygiene, cleanliness, clean water, sterilization techniques have been helpful. But what else do you have for us?
Yeah, so I think the main thing is that we've seen that mortality rate come down significantly. We've seen the case rate come down significantly. We're like, now since the vaccine era, we're 95. We've reduced cases over 95% at this point, and we've reduced fatality by 99%. When it comes to tetanus, we've seen, as Dr. Michaels alluded to, a lot of different, in less developed countries, we've seen a lot of progress because we've gone through these processes of trying to really implement better vaccinations in mothers and trying to reduce, these non-sterile blades and everything that when it comes to birth. And with tetanus immunoglobulin, any patients who come in who haven't gotten their vaccination, they come in with a contaminated wound. We wash it out as well as we can, and we give them then tetanus immunoglobulin to try to help protect, even if they do, to give them the antibodies they need, even though they aren't immunized.
And so that would be our next one: the treatment. If a patient of yours has tetanus and is not vaccinated, the treatment is tetanus immunoglobulin. I think you all said in the U.S., intubate and sedate due to the extreme pain associated with it.
Yeah.
And then you talked about having rhabdo, et cetera. So watching out for those conditions. Anything else?
Yeah, so the mainstay of treatment really is oftentimes the bacteria can be associated with a foreign body, like a splinter that's stuck in the body, and so these could be fairly minor contaminated wounds. We had an Amish patient who had we ended up finding a splinter in his foot after we diagnosed him with tetanus. And so removing that foreign body is really important because the bacteria can stick onto that foreign body and can be harder to kill with the antibiotics. And so you have to get the foreign body out. We give tetanus immunoglobulin, which is against the tetanus toxin. And so it's going to bind up any toxin that hasn't gone to the neurons yet and cause the problems. So it should keep things from progressing any further. And then we treat with antibiotics. Marian alluded to penicillin G is one of the mainstays of treatment. We primarily in the United States, I think, use metronidazole at this point, which is also known as Flagyl, as it treats anaerobic organisms. And then, outside of the infection part of treatment, you really need your ICU colleagues to, intubate these patients, put them on neuromuscular blockade so they can't spasm. And then essentially, it's like a daily or every couple days thing where we lift that neuromuscular blockade to see if they are still spasming. And then ultimately, at some point, they'll hopefully get through that. And then their nervous system actually mostly goes back to normal, thankfully. But the mainstays of treatment are really like managing those symptoms in terms of the neuromuscular blockade, sedation, and intubation, and then the treatment of antibiotics, removing any foreign bodies, and giving tetanus immunoglobulin.
Now, this is a question. Tell me if you don't know it, but how quick is it for anyone to get tetanus immunoglobulin? I can't imagine we just store it. I don't know, actually.
We do. I mean, we certainly have it in our have it in our emergency room. We have given it to. I think I actually saw during fellowship a patient with Dr. Michaels in the emergency room that was an Amish boy who had not been immunized, and so we gave him tetanus immunoglobulin for a cut, and he was maybe having a little bit of trismus starting, and so he ended up doing fine as well. But yeah, we do store that. We have it on site, and we can give it at least certainly in. I should say most hospitals, they probably have tetanus immunoglobulin around.
May I add something in, Dr. Rapsinski? I just, I'm listening to you go through this, and I just want to emphasize, if more people don't vaccinate, because vaccination is what we should do. That is the prevention, which I know Glenn's going to talk about. But this is expensive. This is not easy to get. And it's not without side effects. And we have it in the emergency rooms, at most emergency rooms, because we have those few people who aren't immunized and need it. But if a lot of people come in that have cuts and scrapes and nail, and injuries from a dirty nail on the ground or something, we're not going to have sufficient tetanus immunoglobulin to give. So this is not a backup. This is like a backup, but we should be prevention. And I'm going to let Glenn take it from there. But I just want to emphasize that.
I think that's great. Glenn, the next thing we have to cover is what happens if we're vaccinated and get the disease. But the floor is yours.
Yeah. So, I think the other thing to emphasize is that the other group of people who will often get tetanus immunoglobulin potentially is people who have gone past the time that they need a booster. And so we all need tetanus boosters as we get older. The recommendation is every 10 years right now, though if you do get a cut after about 5 years, we still recommend giving another booster at that point to boost those antibodies after 5 years. And so tetanus vaccine is the one that you probably remember as the one causing the most pain in your arm, because you may get that knot in your arm whenever you get your tetanus shot, but that just means your body's making a great immune response and you're going to have lots of immunoglobulin to protect you. If you are vaccinated against tetanus and it's been within that 5-year period, oftentimes we will not have to do really anything with a contaminated wound or cut besides wash it out really well. As I mentioned, if you are past that 5-year mark, we will give you another tetanus booster. You don't necessarily need tetanus immunoglobulin in that case. And it's really unlikely that if you are vaccinated against tetanus and we give you that booster, that you are going to actually get tetanus, the disease. And so if you're exposed to those types of cuts or anything like that, it's important to look back and remember your vaccine history and know when you got your last tetanus shot, so we can give you the proper treatment in that scenario whenever you get those contaminated wounds.
Yeah, if you had your first 3 shots, right, you don't need the immunoglobulin, but sometimes people don't know. And then, because this is such a horrendous disease and such high morbidity and expense. You think of how many days, Glenn, how many days those kids stay in the ICU intubated. It's days and days and days, and can be weeks that it can last. That the emergency departments will err on the side of giving the immunoglobulin if they don't know if you've had your immunizations, your primary immunizations. But you're right. If you just have a cut and you come and you're beyond the 10 years, you just need the booster to prevent it.
Well, that was great. That was just wonderful. So now shall we change gears and cover hepatitis B?
Sure. I'd love to talk about hepatitis B.
All right, Marian, take us back to Microbiology 101. First year of med school. Tell us what we're dealing with, please.
Okay, so unlike tetanus, hepatitis B is a virus, and it's a DNA virus. And even though it's called hepatitis B because it was the second one discovered in terms of the hepatidities, it is so different from hepatitis A, which is an RNA virus and is fecal transmitted. This one is mostly one of the ones we think of as bloodborne transmission. So hepatitis B is a DNA virus, and yeah, that's what you need to know.
Now, this one's going to be fascinating, Marian. Please give us our epidemiologic data,
Yeah.
like how much of it we see now versus what we used to see before the vaccine.
Yeah. So I'll tell you, hepatitis B is one that's still around. So in the United States, there's still about somewhere between 750,000 to 2 million people that have chronic infection with hepatitis B. So it's there. Whether they know it or they don't know it, it's there. And with that kind of numbers, if the women who are childbearing age and who could be pregnant and having a baby, there's usually about somewhere between 20,000 and 25,000 each year in the United States. Now, if we don't know about those infections and we look at what the epidemiology was before we had immunizations, which came out in the 1980s, so relatively recent compared to the tetanus vaccine that we've had for a long time. If we looked at how many babies were infected with hepatitis B, it was around 20,000. So around 20,000 children, I would say under the age of 10 would be infected. And the most common place for those children to get infected was, in fact, from a mother who had hepatitis B and didn't know about it. Okay, so that's important to keep in the back of your mind because people are like, what the heck? I'm pregnant? I got my blood test. I was hepatitis B negative. Why on earth does my baby need to have a vaccine at birth? Why do they have to get it at birth? My baby's not a drug user.
Right.
So, so let me come back on the epidemiology first because people always think about drug users or people who are having sex for exchange for drugs or sex in exchange for money as being high risk. And it is true because it's a bloodborne pathogen. It's very common to be from the blood that it gets transmitted. So I think we need to think about this before we come to the vaccine and why we really feel so strongly in pediatrics about getting that birth dose in. So this virus is in the blood, replicating like crazy if someone's not treated and if someone has a chronic infection, and they may not know it until late in the disease. And a very small inoculum of blood can transmit it. So if someone has hepatitis B and they don't know it and they're brushing their teeth, that little minute amount of blood from their gums can have hepatitis B on it that can then transmit to somebody else, including a toddler who picks up that toothbrush and puts it in their mouth. It can transmit from sharing a razor, even if it doesn't look like there's any blood on it. And when someone has a needle stick in the hospital and everyone gets all freaked out about HIV, which of course I'm not dismissing in any form or fashion, I really worry about the transmission of hepatitis B if they are not immunized previously, because it's 100-fold more infectious than something like a human immune deficiency virus. It also can survive on surfaces for a long time. It's a hardy virus, so it can stay on surfaces for about 7 days. So that's really important to know, and that's why households where someone is infected can often have the transmission horizontally. Okay, so that's sort of the epidemiology. With babies that are exposed to hepatitis B, the risk of going on to have chronic infection is extraordinarily high. So about 90% of babies that get infected with hepatitis B in the first year of life are going to go on to chronic hepatitis B, which has all the problems of cirrhosis and cancer, hepatic cancer, hepatocellular cancers. If someone's older, so say they're 1 to 5 years of age, that risk goes down, but it's not zero. It's still around 30 to 50% risk of having chronic disease, as opposed to an adult who gets infected, really more like 5 to 10%. So most of the time, a person who's older who gets the infection, they're going to get over it. Now, there's such a huge amount that still is a big problem, but the young child, the kids that we take care of as pediatricians, they're the ones that are at risk for having a chronic disease and having all the problems that come afterwards. So that's why we feel so strongly about getting the vaccines in. You can say, well, I know that I'm hepatitis B negative. Well, you don't know if everyone around you is hepatitis B negative, and that baby is still at risk for getting hepatitis B from somebody else or somebody close. Or we have in our country, unfortunately, we have a number of times where the hepatitis B lab is misinterpreted. So someone thinks they're negative, but they're not. We have times where we're not testing women, or women aren't coming for prenatal care, or something happens that test gets lost or not communicated appropriately. And so that happens too frequently for us to ever take a chance. So yes, if I knew that you were hepatitis B and everyone around you and everyone in the world that's exposing that baby is hepatitis B negative, if you wanted to wait, that's okay, but not really, because what about if you miss coming to your appointments? So here's a system where when we had universal hepatitis B vaccination, we went from having 20,000 cases in kids under 10 to 2023, the number of babies that had hepatitis B under 10. 7 documented. I mean, my God, this is success. Why are we changing something that is so successful?
Yeah.
So that's my spiel.
So for the physician, for what the patients are going to push back here, what if they say to you something to the effect of, okay, I don't think anybody has it in my area, but how does that one vaccine shot at birth protect my baby if their uncle comes and visits and potentially has hepatitis B? How does that one shot help?
Yeah. So that one shot starts the immune system working, because you really need time in between the immunization. So the sooner we get them in, the better we have the chance of having that baby protected. If they go to play dates and someone else's house, if they go to daycare, if they have babysitters coming in, there are lots of times that there are people that it's not that they're not telling you, they're hiding something. They often don't know that they have hepatitis B either. And so that's really why we want to get that immune system revved up and working the second that baby comes into the world, so that we can get their next shot in the series in at 1 month of age to 2 months, and then the next one 6 months later, so that we have as much protection as early on as possible. And we know with this strategy that it is safe. That, yeah, there's a little bit of pain with a shot. I know all of us have had vaccines and had needles, and there's a little bit of pain. There can be a little bit of redness. There is not seizures. There's not Guillain-Barré disease. There's not anaphylaxis. There is not SIDS. This is a very well-known vaccine that has been well studied and has been being used universally in babies since the 1990s. So every single baby around, many, many babies, hundreds of thousands, millions of doses worldwide have been given. And so we really know the safety of it. So why would we change something that's working, a strategy? And people say, well, my kid's never going to grow up to be a drug user. Well, I hope that you're right. I do hope you're right. What if your child wants to be a doctor? What if they want to be a cardiac surgeon? What if they want to be a person on the first line, and they are a policeman, they are an ambulance, an EMS person? What if they are traveling around the world and they get in a car accident where the blood transfusions are not as well tested as they are in the United States? There are so many reasons to have this vaccine and have this protection for their health. And my God, it is the first vaccine that we had that protects against cancer. Against cancer. So no brainer to me, and hopefully to be able to help our families do what's best for their children as well.
For those of you at home listening, I have been trying for years to get Dr. Michaels on this podcast with no success until now. And now you all see why. So, Marian, this is fantastic. So you've talked a little about it. Can we talk more about, well, first, let's talk about, unfortunately, we are already seeing less babies getting vaccinated at birth, everything going on. So what should we as physicians, frontline physicians here, be looking for? How should we recognize this disease or at least think about it in a patient coming in if it's a potential cause?
Yeah. Well, that's a great question. And unfortunately, I don't have a great answer for you because hepatitis B in a young person is almost always asymptomatic. So whereas an adult, you might have 20% of them, 30% of them have acute hepatitis where they get fatigue and they get fevers and they get some jaundice or dark urine. The baby that's infected, they're not going to have symptoms like that. The 2-year-old who's infected, they're not going to have it. So if you have a family who decided not to vaccinate at the birth hospital, the onus is on us as their healthcare providers that we try and get them vaccinated early as well. So if we miss that birth dose, which I'm hoping we don't do, I know that it's happening. I realize what's happening in the world, but I'm hoping that we're able to change this back. But if they do miss it, you really want to try and get those vaccines in as soon as possible because the symptoms aren't going to be there. And once they're infected, then the risk of chronic disease in that young person is extraordinarily high. And the treatments are not easy. It's like triple drugs. One of them's like an interferon, pegylated interferon. It causes you horrible myalgias and aches, and they have side effects. The tenofovir, the lamivudine, the other drugs that are used. Most of them are approved for adults. There are some that are approved for kids over 2, some that are approved for kids over 5. But it's not easy treatment. It's not easy treatment. So really, prevention is what we want to do. 25% of the kids that have chronic infection from birth or from that first year of life are going to go on to die. And, anyone who's had to deal with a child with liver cancer, it's not an easy cancer to deal with.
Well, then our next point was going to be morbidity and mortality, but I think you've given us that information. So acute hepatitis B in the neonatal period has a much higher convergence to chronic hepatitis B. And of that group of chronic hepatitis B, a portion of them will go on to hepatocellular carcinoma and then, unfortunately, death. Is that correct?
Correct. That is correct.
Okay.
Now, this used to be a big reason that we did transplants. The people would go on to liver disease in the early days before we had treatment available. It was actually a contraindication to transplant because we would just infect the new liver. So when you didn't have enough livers to go around, why would we do that? In fact, this is really going back in time, but Dr. Starzl even tried baboon liver transplants with the idea that the baboon livers wouldn't get infected with the hepatitis B. But thank goodness, better than that, we do have some treatment available. So not the first line. The first line should always be prevention, prevention, prevention.
Well, since you brought it up twice, Marian, can we talk about the treatment if someone's not vaccinated?
Yeah. So if you're not vaccinated as a young child, we don't have treatment for the babies. So we do wait until we know that it's a chronic infection. And then we usually try to do a treatment of at least 3 different drug combinations, one of them being a shot that helps with the immune system. So a child who doesn't have active liver disease, so I'm not saying active virus, the virus can be there. They can be shedding. They can be risk to infecting other people. So we'd want everybody immunized in that group. But then eventually, when they did go on to liver disease, then we would want to get them into treatment. And usually, it's the hepatologists that are doing that treatment. So we would refer to that group. We would also, like Glenn was talking about, that for tetanus, if we know someone's had an exposure and doesn't have immunity already, we do give hepatitis B immunoglobulin along with vaccine to try and prevent them getting disease. So if we know that a mother is infected with hepatitis B, that baby, when they're born, gets hepatitis B immunoglobulin plus the vaccines. And then same thing if we had a household, if we found an adult had hepatitis B in the household, we would want everybody to be immunized. And if they're not immunized, to get hepatitis B immunoglobulin for prophylaxis, and then get immunized to have long-term protection. I don't know, Glenn, did you have something else to add? You always have brilliant thoughts.
No, I mean, I think you covered all the hepatitis B treatment options that are out there. I think you emphasized the most important thing, which is prevention is the best treatment in the case of hepatitis B. And that, I think we as residents certainly had these times where, I was called up from the NICU on several occasions to have conversations with parents in the newborn nursery about hepatitis B refusal, and that often went along with things like vitamin K refusal and erythromycin refusal. And so we had to have these conversations. And I think they're always challenging. You try to come at it with a sense of desire to understand where they're coming from with it, rather than going in with preconceived notions about what the family is worried about, because you can often trap yourself into talking about something they weren't even worried about or they never even heard about if you go in assuming that you know what they're worried about. And so, I mean, I think you hit the main point, the most important point, which is that prevention is the mainstay of treatment. That I think, and Marian can correct me if I'm wrong, but I think the toxicity and the side effects of the medications we use for hepatitis B treatment are not particularly gentle and not particularly nice. And I wouldn't want to have to go through those medications personally. And I don't think I would want my child to have to either.
Yeah. Glenn, I'm listening to you talk about your experience with going to the NICU. And I was like, wow, I can't think of when I was a resident having to do that. And then I suddenly oh my God, because I was a resident before we had the hepatitis B vaccine. So I was like, I never do that. So thank you for sharing that. That's right.
So I guess now that if we're vaccinated and get hepatitis B from one place or another, is our concern for chronic hepatitis B and hepatocellular carcinoma, is it zero?
Oh, yeah, that's a great question. It's not zero. Nothing in this world is zero. So so there are times where people don't have a great immune response where we're able to measure the antibody. Sometimes despite that, they'll still have a nice T cell response. So we do know if you're fully vaccinated, even if we don't know your response, we do know that if you do have a hepatitis B infection, so a breakthrough, despite having done everything you could to not have that happen, we know the risk of chronic infection is less, and the risk of cirrhosis, of liver disease, and the risk of hepatocellular carcinoma is less as well. So the vaccine gives you protection. Now, in our people that are very high risk for going on to severe disease or for being infected, we will do recommend having your antibody titers checked. So, for example, a child who is say 10 years old and they were fully vaccinated and they're going to need a liver transplant or a heart transplant. And so they're going to be immunosuppressed. Or they may even get an organ from someone who has hepatitis B core antibody and you don't know, can I use that organ or not? In those people, I will test I'll test them during their evaluation, their pre-transplant evaluation. And if they don't have a measurable antibody over 10, then I do ask their pediatricians to go immunize them again. Same thing if there's an adult who's a healthcare worker or is a first line EMS officer or someone who's going to be out there first line of policemen, if they're not immunized and they're older, we actually have some stronger vaccines that have better ability, but those are all for over 18 years of age. So we might re-immunize you, boost you to try and get your vaccine titer up.
Well, I have to tell you, I have enjoyed this thoroughly. I mean, this is great. Now, this is everything I wanted to cover, and I always ask my guests, is there anything we didn't talk about that you wanted to talk about? And we'll go in the same order, Glenn and then Marian. So, Glenn, anything we didn't talk about that you wanted to talk about?
No, I think I always enjoy the opportunity to listen to Marian talk about vaccines, and so I'm glad I got to listen in and hear her talk more in depth about hepatitis B. She just did a grand rounds recently that was wonderful as well, and so it was great. I think the take home message that I always try when I talk to residents and stuff about addressing vaccine hesitancy is to remember that vaccine hesitancy is not a monolith, and it's not something that like everybody is not coming into that appointment with the same concern about vaccines. And so asking why and asking what's going on and how they got to the conclusions that they got to is the most important step in this, to get yourself to the point of understanding where they're coming from, because it's the only way. You have to meet them where they are to bring them forward into what you want them to be doing, and what is best for their child medically. And so I think you have to find out where they are to get to that point. And so that's my big piece of advice usually, because you can end up down a bunch of rabbit holes talking about things they didn't even care about or didn't even know about if you end up coming in assuming what they want to talk about.
Marian?
I think Glenn said it so well. And, I thank both of you for having me on this. I apologize for not having been on your program before, but I'm delighted to be on today, and certainly will be delighted to do so in the future as well. But I think Glenn said it very well. Have an open mind. Be curious as to why, what have they heard? What can I help with in terms of correcting and just giving advice, not coming off patronizingly. People want to do the best for their child, and we want to help them do the best for their children. But prevention is always the best way to handle things, not trying to treat once there's disease. We really want to be able to prevent these diseases. And I have to thank you, Tony, so much for having these podcasts and educating everybody.
Marian, the pleasure is mine. I'm so happy you and Glenn came on today. Thank you both so much.
Yeah, thanks for having us. Bye.
Thanks for having us, Tony.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.